I want to thank Lymphoma Australia for helping organize this, and I'm thankful for IWCLL for having a meeting that we can piggyback on, and of course I'm thankful for the doctors here attending and giving of their time so generously and so freely. So let me start with the most basic question of all, and any one of you can answer. What the heck is CLL? What is this disease that none of us knew about until we found ourselves in a doctor's office with the diagnosis? Bill, you want to start with that?
Sure. It's interesting the way that you frame that. Most of the patients that I see come to me and give me the story that their diagnosis was made just incidentally. They were getting routine follow-up with their physician, and they noticed that the white blood cell count was elevated and did some further testing and made the diagnosis. That's the typical scenario that I hear when patients come. Now, most of the time they're previously diagnosed before they come to see me at MD Anderson, but this is the history of the majority of patients. There are an occasional patient who notices that their lymph nodes are enlarged and seeks a diagnostic workup because they have enlarged lymph nodes. It's rare for us to see patients who have very advanced disease at their initial diagnosis. And I think that sort of gives you an idea, a first idea about the disease and the biology of the disease, and that is that CLL is a malignant disease, but the malignant cells usually aren't that aggressive. They're an abnormal version of a normal cell, which is a B cell. Something has happened to this B cell that has made it live longer and not die.
And that's a specific type of lymphocyte, right?
A B lymphocyte. And so the cells are mature cells that have the typical characteristics and features of an adult version of a B cell. That's important because we distinguish leukemias and lymphomas and other malignant diseases by their aggressiveness, and their aggressiveness usually correlates with how immature the cells are. So for example, ALL would be a B cell disease, but a B cell disease of a very immature cell that has become abnormal.
And that's acute lymphocytic leukemia.
Right, that's acute lymphocytic leukemia. So CLL is a disease of mature lymphocytes. They're relatively slow growing. They do have a birth rate in the body and a death rate. The birth rate is usually higher than the death rate, and that's why you get accumulation of more and more cells. And the cells like to do what typical lymphocytes do. They'll circulate around in the body. So usually in somebody who's not been treated, we can usually show that they're in the blood and in the lymph nodes and in the bone marrow and the liver and the spleen. And in some cases, the disease is not very active at all, and things are relatively stable and can be stable for a number of years, and there are some patients who never need treatment. And then there are other cases where the disease is active and becomes more active, and you get more disease, and eventually patients need to be treated. But it is a malignant disease. There's some heterogeneity or diversity in how quickly or rapidly it's growing and advances. There's heterogeneity in terms of response to treatment, and there's heterogeneity in terms of how much the disease actually impacts on the patient's life in terms of needing treatment or shortening their life expectancy.
Dr. Trotman, could you tell us a little about what SLL is? Because it's a little confusing, because CLL we're here at a lymphoma meeting, but CLL is a leukemia and a lymphoma. Can you explain that a little to us?
Yeah, I think for a very long time, and Bill and Adrian can correct me if I'm wrong, but for a very long time we've tried to tease out the difference between CLL and SLL. And we've really failed to, except for one overriding feature. SLL, small lymphocytic leukemia, arises in the lymph nodes and doesn't cause this raised white cell count, this clone of lymphocytes that are circulating in the peripheral blood, in the circulation. So it predominantly arises in the lymph nodes. That's not to say that CLL might not transition to a chronic lymphocytic leukemia later on in its life cycle. Is that a sort of fair summary of it?
Yeah, and I've had several patients who've started out as SLL and have, as the years go on, they start to develop circulating lymphocytes and leukemia cells and transition from an SLL diagnosis to CLL.
Yeah. But the actual biology of the disease, aside from that, we really haven't been able to tease out why, SLL starts in the nodes and CLL starts in the leukemia. And I think having identified that the biology is essentially the same, our treatment approach is the same, except for when SLL patients get excluded from CLL trials.
Dr. Wiesner, anything you want to add to that? Or?
I would actually second that, and I think that's an interesting way to say it. Patients with SLL excluded from CLL trials. In the US, sometimes it's also that maybe oncologists, lymphoma doctors see SLL patients, and hematologists see the CLL patients. And some of the differences in how the diseases are approached are actually the different doctors patients see, and are, as you said, not really grounded in differences in how the disease behaves or responds to treatment.
As a patient, I like the fact that it's both, because we get access to leukemia resources and lymphoma resources. So I don't see it as a disadvantage to having both, because we're at a lymphoma meeting, but leukemia meetings also include CLL, so we get education and support from both areas. So as a patient, I kind of like the fact that we have a foot in both camps.
I would add also that in terms of the prognostic factors and all of the discussions that we have about treatments and outcomes, they really apply to both diagnoses. So patients with SLL, when they hear these discussions that are framed around CLL, it really pertains to them as well.
Dr. Wiesner, how do you make the diagnosis? So somebody comes in, they've seen their doc for a routine physical or something, and their lymphocyte count is high. How do you make a certain diagnosis of this?
So the mainstay of making the diagnosis is characterizing these lymphocytes in the blood. That typically in the blood count it just says lymphocytes. So the next step is to find out what type of lymphocytes these are. And again, CLL cells are B cells, and there are characteristic markers on these cells that we can measure in diagnostic laboratories. So the test is called flow cytometry, and tells you, first of all, it's a B cell, which then has characteristics that let us identify these cells as chronic lymphocytic leukemia cells. In addition, flow cytometry can sometimes give a first indication of what subtype of CLL this is, going back to some of the heterogeneity that is in CLL. But so the first diagnostic step really is to send the blood to a flow cytometry lab and get that test done.
And if it's SLL, you need to do a biopsy to make the diagnosis, because you don't have the tissue in the blood. Is that correct?
That's in essence correct, except that most SLL patients have some of these cells circulating in the blood, and I would be comfortable to accept the diagnosis as SLL if there is a patient with lymph nodes in the peripheral blood. There are the cells that have the characteristics of the CLL SLL cells. I would not necessarily, don't quite meet. So the difference is numeric, right? More than 5,000 cells in peripheral blood means it's called CLL. Less than that, with lymph nodes, it's SLL. So I wouldn't insist necessarily on a lymph node biopsy.
I think one good thing about CLL is it's not a difficult diagnosis to make. So if your doctor tells you you've got CLL, they're almost always right.
Now, can't it occasionally be confused with mantle cell and some other things? I know that sometimes there are some atypical cases. I don't want to go down that rabbit hole too far, but isn't it occasionally difficult?
Right, there you'll see a rare atypical case, but for the most part, we've done a lot of work at Anderson in terms of analyzing our diagnosis compared to what patients come as, and it's much more common for the other leukemias to change the diagnosis when they come to Anderson and get our workup than CLL. It almost never happens that we change the diagnosis to a different disease.
So here's an area that there might be some diversity in Australia versus the US, and I'd be interested. So now I've got the diagnosis, I've got the disease. What tests should my hematologist order on me? What tests should I be expecting? What tests shouldn't I have when I'm diagnosed? Do you want to start with that?
Look, that very much in Australia depends on the patient and whether they're about to be needing treatment. And we can have a separate conversation about the criteria for treatment. And their capacity to tolerate certain treatments also comes into account. So most patients in Australia would not get a bone marrow biopsy for diagnostic purposes because it's not necessary. As Adrian has pointed out, it's very easily diagnosed in the blood. But if they were enrolled in a clinical trial, then unfortunately many clinical trials require quite a number of bone marrow biopsies. For those of you who can remember that aching hip. But we also, in a number of patients, particularly just before we start treatment, we will want to do FISH analysis. But the difficulty with that
Can
in
you
Australia...
explain what that is?
So, that's very... I've never quite explained it to a patient population. Maybe one of my colleagues might do it better. But where you're using what's called fluorescence in situ hybridization, the acronym is called FISH, is where you use a specific probe for a specific mutation or genetic abnormality that is expressed exclusively on the chronic lymphocytic leukemia cells. And we capture these cells, we grow these cells, and we try and go hunting for these specific probes. And there are probes for poor prognosis chronic lymphocytic leukemia, and there are probes which characterize a better prognosis. And they may impact on your therapeutic approach. But unfortunately in Australia, and I think this is a real tragedy, that it is not readily available for everyone in Australia on our current, what we call our Medicare benefit schedule, the MBS. FISH is not funded. So we have to be very selective about whom we do FISH because the laboratory or the patient themselves has to absorb the costs. And I'll be the first to admit that that is wrong. It's probably the short answer. Would you not agree?
Yeah. So you
Can I get hold of the mic up a little bit?
You can't routinely have FISH on everybody who needs to start on treatment. Is that what you're saying?
Short answer is no. We have to be gatekeepers and we have to be selective. And unfortunately, a lot of patients don't.
Because everybody should have
physician
FISH.
choice. Yeah. Look, we can say to everyone, look, you can have FISH and it costs, I don't know, perhaps one of the patients who've paid for FISH can tell me.
$300.
About
$300.
About $300.
Yeah.
You know how much it
I
is
thought it was
in
a
the
bit
US?
cheaper than that.
Yeah, it's like
About
$1,500. $1,500.
$1,500. Yeah, wow. I think everything in
It's
Houston
cheap.
is 4 times the price of what it is.
Yes. And go ahead, Dr. Wiesner, you going to add something to that?
So, in principle, I agree that FISH is a very important test before starting treatment. I don't think it's necessary at diagnosis or mandatory at diagnosis. It's informative. It's always informative. But when do we really need it? I think we would also need it if we can act on the information we find. And so the question would be, what would you actually do with different FISH results? And if, like 5 years ago, we did FISH on everybody in the US, but we treated everybody the same anyways. What we've learned is that, yes, some of the FISH abnormalities mean that chemotherapy may not work as well. So if there is a decision point, if we can choose different treatments based on the FISH result, then I think we need it.
And that's certainly a case in point when I was able to identify through FISH a patient with a very poor prognosis because he had a suppression of the guardian of the genome, the so-called tumor suppressor gene that is very important in
The
helping
P53 or
P53,
17p
yeah, the
deletion,
17p deletion. Now he had that mutation, which is, in fairness, quite uncommon. It's only about what, 5, less than 10% of patients at initial, not initial presentation, but perhaps just before requiring treatment. And that enabled me to send him from my hospital here, Concord Hospital in Sydney, to another hospital half an hour's drive away to be enrolled in a first-line treatment study for his 17p deleted with idelalisib and rituximab, and we can discuss that when we go on to treatments. But that, that did have an impact for him, for sure.
Let me ask one other thing, because I didn't hear this mentioned, and I'm kind of glad I didn't, but what about the role of CAT scan and PET scan in diagnosis of CLL, or not so much in diagnosis, but at time of diagnosis? Dr. Wiesner, do you see any role for CT or PET scan?
For the way we talked about how CLL is found, let's say it's an incidental finding on a blood count, I don't see that you need CT and definitely not PET scan. Both of these both of these diagnostic forms have potentially a role during the course of CLL. But at diagnosis, I don't see a need for either of these tests.
Yeah, I would agree. I mean, you can usually, the nodes usually are enlarged generally, and so you wouldn't pick up by CAT scan, for example, big huge nodes in the abdomen when a patient who didn't have any nodes in their axilla or that you could fill in their neck or in their neurons.
So, when you're diagnosed with CLL, the almost universal approach for most patients is watch and wait, to which a lot of patients think, are you crazy? You just told me I have cancer, and now you're telling me you're not going to do anything. Can you explain, Dr. Weirda, why watch and wait is still the standard of care for most patients?
So many years ago, they did clinical trials where they took patients with early stage disease and randomized them to treatment versus observation. And those trials, when they looked at the overall survival, there wasn't a difference in the overall survival between those patients who got early treatment versus watch and wait and treatment when they had indications to start treatment, things like symptoms or low blood counts. So for years, the approach has been watch and wait until patients have an indication to start treatment. Now, we know a lot more now than we did back when those trials were done about who might have higher risk disease, because those trials, because they took everybody, included some patients probably who never would have needed treatment. So now we're a little bit more informed about the heterogeneity of the disease. We have some tests where we can identify patients with higher risk, and we have better treatment, better chemotherapy, better targeted therapy, etc. So I think that this discussion about watch and wait is an important one. I think we need to do the clinical trials and research, because I'm convinced that with the newer agents and with the newer treatments, there are patients who would probably benefit with earlier treatment rather than watch and wait, because the response is better when there's less disease there, patients' immune systems are more intact, etc. But we need to do those clinical trials to make that observation and demonstrate that that's in fact the case. So until we do that, we're still at watch and wait and treatment when patients need treatment.
Absolutely agree.
Dr. Wiesner?
Yes, I agree with maybe the little bit of a caveat. I'm a little reluctant whenever I hear that it may be time to move away from watch and wait, because I actually think it serves many people very well. And we know that some treatments definitely, maybe all treatments, have their downsides, can leave some damage from the treatment. Now with the newer agents that we call newer agents, we think there's less of a concern, but the experience is still pretty limited. So while I agree that some patients, but I think it's a minority of patients, would be potentially well served by what we call early intervention. I think for the majority, watch and wait for somebody who has no symptoms is still the right thing to do.
We've got to remember the adjective in front of this leukemia. It's chronic. And when patients, first come to us as haematologists, we often have to unpackage the enormous anxieties of having a leukemia and stress that the most important word in the label is chronic. And that's why watch and wait, I'm sure, will continue to remain very important for most patients. And we may have to, as we get these fancy new drugs, as they start becoming used more and more in the frontline setting, in the clinical trial setting, we may have to be careful and not get too enthusiastic and push back against the natural inclination when a drug is very well tolerated and very effective at getting leukemias into remission, not to automatically start using them.
And I think Dr. Vera really said in clinical trials. I think that's the other important aspect. I think in clinical trials, it's a fair question whether for certain patients starting early is better than waiting. But this should only be done in clinical trials.
So, Dr. Trotman, you talked a little bit about indications for treatment. So, what are those indications for treatment? When do you decide to treat a patient sitting in front of you? How do you make that decision? What criterion are you using to leave the watch and wait period behind?
Yeah, look, there are some very well established criteria that are internationally accepted as criteria for when we start treating patients. And it's very much based around the fact that when patients start getting symptomatic from their leukemia, it's time to treat. And when they start getting very low blood counts, in particular anemia is a manifestation that drives the need to treat. It's also about the tempo of the disease. As you see the disease growing rapidly and the hemoglobin might be dropping rapidly, and making sure that drop in the hemoglobin is because of the advancement of the disease, not because of an immune problem related to the disease. They're the criteria that trigger starting treatment. And I suspect every individual hematologist or hemato-oncologist applies those criteria with slightly different nuances in different patients perhaps. I'd be very interested to hear what my American colleagues have to say in terms of their triggers for treatment.
So, I mean, I would agree that there are formal criteria that we use to evaluate whether or not patients have active disease to initiate therapy. There is definitely subjectivity in terms of what we use to start, how we determine when a patient actually needs to start treatment. Some of the criteria are somewhat subjective, so how one patient interprets fatigue and how they report their fatigue is going to be potentially completely different than another patient, and how much that fatigue really impacts on a patient's quality of life and what they're able to do, and is going to be different between patients. Night sweats, it's a little bit less subjective, but the fatigue aspect of it is there's a lot of heterogeneity in that in terms of what we use to start therapy. The counts are a little bit easier in terms of using objective data to say, okay, your platelet count's less than 100, it's been less than 100 for a couple of months, we need to plan on treatment.
Is there a white count, Dr. Wiesner, where you'd say, okay, their lymphocytes are now over 100,000, over 300,000, that you'd say? I know with other diseases, the levels are important. CLL, is there a count that you would say the patient sitting in front of you is feeling well, is not anemic, their platelets are adequate, but their count is just climbing and climbing? Is there a count where you'd say, it's time to treat this?
There's not a count where treatment is automatically needed. So there's no absolute number. And 100,000 you picked, definitely we have many patients who are above 100,000 and continue asymptomatic in our clinic without treatment. There are probably some levels very high where sooner or later your doctor will be nervous about the count, and I think the level has to do with how many CLL patients the particular physicians see. but there is no absolute number. You said rising steady. Going back to if the rise is very fast, that's so more than doubling every 6 months, for instance. That's typically something we would take as an indication that treatment is near or that treatment is indicated.
And there's not a number that I use, as I would agree with what Adrian's saying. I will say, though, however, I will watch patients closer if their white count's over 100,000, say. But I don't act on that. I just keep closer tabs on them.
I certainly started threatening a very elderly woman with starting treatment when her white cell count hit over 200 3 years ago, and said, and I'm going to see you soon, or I'm going to see you again in 3 months' time, and then again I saw in 3 months' time, and again in 3, and she still hasn't needed treatment. So, there is no absolute count.
And I've heard of patients with 400, 500,000 who haven't needed treatment. So let's get into an area that's maybe even more controversial, frontline options. So let me start with the Americans first. So maybe Dr. Weirda, if you have a patient who comes in, and I know it's going to depend on what kind of factors are you looking at and what kind of frontline options are you offering someone for their therapy. And let's say it's a low-risk patient.
Low risk, how do you define low risk?
Well, I'll let you define. So I'm talking about somebody without a 17p deletion,
okay.
is relatively healthy and well.
Okay, so just a high-level view of how I would assess a patient who needs treatment. There's a couple factors that I pay close attention to, and the data support that. One is age, because we know the more intensive chemotherapies are not as well tolerated by older patients.
And age, is there a number there?
65 is usually the cutoff, and that's supported by the literature. I will give patients 70 or so treatment that I would give a 65-year-old if they're in good shape, and I do manage them a little bit differently the older they get, because I have a much lower threshold to dose reduce the chemotherapy if I see any indication that they're having difficulty tolerating it. So age, because the treatments are different, and the initial treatments are different that we use based on age, and then FISH, as we were talking about, is a very important test for me, and I would say that I would do it in any patient who needs first-line therapy. And the reason is we want to identify those patients who have a 17p. Although they're infrequent, it's a test I would definitely pay $300 to get the information for. Because the treatments are different for the patients with a 17p. We know chemotherapy basically is ineffective with those for those patients with a 17p deletion, and I would avoid chemotherapy if I had a 17p deletion. So age, the younger category of patients who don't have a 17p deletion. The standard, there are chemotherapy combinations that there's data for. The regimen that we've used a lot at MD Anderson is the FCR regimen. That is effective at getting at least 70% of the patients in a complete remission. And so for a younger patient, younger than 65, who doesn't have a 17p deletion, I would say, and the data from the German randomized trial support that as being the standard of care for untreated patients who need frontline therapy. The caveat that I would say to that is, so we at Anderson, we don't want to give everybody standard treatment. We want to put them on a clinical trial, and because we think our clinical trials offer something better than what the standard of care is. So now for the frontline younger patients, we know with our FCR experience that the patients who have a mutated V gene do exceptionally well with FCR. 2/3 of them
So could you just stop and explain that? Because that's another prognostic test, right?
So it's another prognostic factor, and it's a gene that's in the leukemia cells, and it can be characterized as either being mutated or unmutated. The mutated cases tend to be a slower growing, more indolent disease. The unmutated cases are those that tend to be quicker growing and have shorter first remissions and subsequent remissions. What we know for the mutated cases, 2/3 of them remain in remission beyond 10 years, and there's discussion among our group about whether or not some of those patients are cured, or a large portion of them are cured. So our clinical trials now look at younger patients and characterize them by their V gene, their immunoglobulin heavy chain V gene, and we're having options that are different for the mutated versus the unmutated cases. For the mutated cases, we're making variations on FCR to try to give less chemotherapy and to introduce the small molecule inhibitors to give a defined period of treatment to get them in a good complete remission, MRD negative, and that's the endpoint for those trials, and we'll see if that's better than our historic experience with FCR. For the unmutated cases, the approach is more of, well, we know we can get those patients in a good remission with chemoimmunotherapy, but we know they're all going to relapse. And so we're trying to open options for those patients that are non-chemotherapy, that push the chemotherapy option back later in their treatment. We don't want to expose them early to chemotherapy. Try new monoclonal antibodies, try some of the small molecule inhibitors, things that are less likely to, or least likely to make them resistant to chemotherapy, and reserve the chemotherapy option for later. So we have a number of trials that we're working on or that are open for the unmutated cases that are not chemotherapy based or non-chemotherapy based. So that's the young group. For the older group, it's sort of the same approach as the unmutated cases. They don't tolerate chemotherapy very well. They don't tolerate FCR, so that's not a standard treatment for the older patients over 65. The standard regimen that the Germans have shown is effective is obinutuzumab plus chlorambucil. And that's reasonably well tolerated.
That's a chemoimmunotherapy.
That's a chemoimmunotherapy regimen. There's a reasonable response rate and duration of remission. So that would be a standard regimen to use for the older patients. BR, bendamustine rituximab, is another reasonable standard chemoimmunotherapy option. I would probably clarify that for those patients, if they're going to get a chemotherapy-containing regimen, they should get chemoimmunotherapy. So they should get a CD20 antibody. They shouldn't get just chemotherapy.
And the antibodies are obinutuzumab, ofatuzumab, and rituximab.
Right, obinutuzumab, ofatumumab, and rituximab.
Which in Australia are effectively rituximab or obinutuzumab.
Rituximab or
Obinutuzumab. No ofatumumab, except for the occasional trial.
And we have a number of trials that we're developing for those older patients that are frontline therapies that are chemoimmunotherapy based. We've done a lot of work with lenalidomide or Revlimid. I don't know if you have that available here.
We have
And then some of the small molecule inhibitors we're also integrating into our frontline approach, and again reserving the chemoimmunotherapy for later in terms of our strategy for clinical trial and clinical research.
Dr. Wiesner, anything you want to add to that in terms, I know every doctor has their own individual approach to this.
So what I would clarify is to say that among 5 different physicians, if you ask them what the standard for frontline therapy, unlike most of the other diseases like non-Hodgkin's lymphoma, you'll get 5 different answers from CLL physicians. So that just illustrates to me that there isn't a wrong approach. There are a number of different options, there are a number of different strategies, and there really isn't, I mean, there are some absolute wrong answers or wrong strategies, like giving fludarabine to a patient with 17p deletion, but for the most part, there's a lot of variability and variation that you see in practice.
Dr. Wiesner, anything you want to add to that? Or
I fully agree, and it's the way our clinics at the National Institutes of Health are is it's all clinical trials. So we've been focusing over the last few years mostly on the novel agents. But I think the summary that Dr. Weerda gave is really excellent and pointing out that, again, there is almost no accepted frontline therapy that you would have to give to everybody. It's a very important point. And maybe one thing I try to tell patients when they come and sometimes find it hard to make the decision to participate in a clinical trial, and they want to go rather with the standard of care proposed by their home physicians. I think at this point there is no obligation to make the right choice. You know, there are several choices that I think, are right. As Dr. Weir pointed out, there are a few that are clearly wrong, but there are few. And so I think some of the good news right now in treatment is that we have several different good lines of treatment, and that if the first one chooses may not work as well as hoped, there are ways to change. And I think that's the important aspect of choosing treatment at this point.
Dr. Trotman, so let me put you on the spot
Yeah,
there.
no, that's
What's
absolutely fine. It's
how
quite
different
sort of
is it?
straightforward in Australia, outside the context of clinical trials, and I'm quite happy to have a look through our app and tell you what trials are available in New South Wales and Victoria and Queensland and everything through each different app. And I think it's important that every patient be aware of them, because I do believe that all patients should be screened for clinical trials participation, which is quite different from all patients should participate in a clinical trial, because the currently recruiting trials might not be the right fit for you. Outside of clinical trial participation, we do have that same sort of split with the artificial split of 65, bearing in mind that there are some very good 70-year-olds and some very frail 60-year-olds with lots of what we call comorbidities, other health illnesses. But for the patients who are older and have other illnesses, we are now allowed in Australia, we have PBS funded obinutuzumab, which you may have heard of as Gazyva, along with the oral tablet, the traditional oral chemotherapy called chlorambucil, that's been around for many decades. And that is, by adding that antibody to the oral chemotherapy, has had, very, very impressive results in obtaining a very good remission for most patients, and very prolonged remission it's starting to look like. So that's an excellent therapeutic option that has only just from August become funded on the pharmaceutical benefit scheme, so available for everyone who's eligible for that in Australia. For the younger patients, we still do follow the fludarabine and cyclophosphamide and rituximab, or otherwise called MabThera, backbone of therapy for younger patients. Whether that will continue to be the backbone in 5 years' time, we really don't know. That depends on the results of clinical trials, which will take some time to mature. So I do believe that fludarabine and cyclophosphamide and rituximab will remain the standard of care outside clinical trials for younger patients for a little while yet. But obviously we hope that the standards of care, all right, are the standards of care for today, and that they will always change. And that that doctors and patients will change with that. So they're the two options that we have available.
So before I move on to second line therapies, let's just take a question about what are the common complications that come not just with the disease itself and with some of the therapies. Thinking about some of the autoimmune issues, some of the other issues. What are the common things? Now you've had a patient, they've started therapy, or maybe even before they started therapy. What are you watching out for as their hematologist in terms of, this is going to get you into trouble with your CLL? What are some of the common complications? Dr. Wiesner, you want to start with that?
So with the chemoimmunotherapy approaches, one aspect certainly is the lowering of the normal blood counts, and that can affect platelets, red cells, and then the neutrophils. So one aspect really is to watch out for lowering the neutrophils and the consequence potentially of having infections during that period. That's a well-known side effect. We know to adjust the dose of the chemotherapeutic agents. We know how to treat the infections. I think the point is to be vigilant, and also especially as a patient during that period, to really look for emergent medical care if there is a fever, if people do feel unwell. Sometimes this also means that the planned treatment of 6 cycles, our standard 6 cycles, will not be completed as planned. that's common and that by itself doesn't endanger or put in question the benefit of the treatment. So lowering blood counts and infections are maybe the two things to really watch out in the immediate period. Now that we are adding antibody routinely to chemotherapy, the autoimmune complications that were a problem with just, for instance, single agent fludarabine have been somewhat less of a concern and not usually don't limit treatment. So that's kind of the immediate period. Longer term potential downsides may be that recovery of normal blood counts can take a while, can be delayed for many months. There's also the potential maybe with years after chemotherapy to have consequences of having had a treatment that can harm normal cells. And I think there's still some debate among colleagues what is the rate of this risk of having secondary tumors that may be related to having had chemotherapy. It seems to be in the range of a few percent of patients who really develop that. It's still a bit of a debate.
Are you talking about myelodysplastic syndrome there, or secondary cancers, or?
So maybe pass that on to Dr. Weirder, because the Anderson group really has done a fantastic job of putting together what are these long-term consequences.
Yeah, so I think what Adrian's referring to are the, as you say, the MDS and AML that can happen as a result of...
Can you explain those?
Yeah, so those are other diagnoses, malignant diagnoses of the bone marrow that result in either developing an acute leukemia, AML, or myelodysplastic syndrome, which is a syndrome where the bone marrow is not able to make the number and quality of cells that it should. So the cells don't work and they don't make enough of them. So the alkylating agents, chlorambucil, not so much as cyclophosphamide and potentially bendamustine, or drugs that are associated with a risk for developing those two entities. And so that's a risk, and as Adrian said, there's discussion about what the actual true incidence is. It's difficult to quantitate that because most patients receive more than just their first treatment. They'll receive subsequent treatments, and the question always is, well, which treatment is this potentially related to, or is it a cumulative effect, etc. The other secondary cancer would be, I would consider as a Richter's transformation, or transformation of the leukemia into a more aggressive form, and the predisposition for that is the prior treatment. We have seen, or we do see, patients who develop Richter's transformation in the absence of having had treatment for their CLL. My opinion is that that's a different entity. We can cure those patients of their aggressive lymphoma with standard chemotherapies. We don't cure them of their CLL, but their lymphoma can be cured with standard chemotherapies in the untreated setting. In the previously treated patients, when they develop Richter's transformation, it's usually a result of exposure to chemotherapy, and the tumor cells are relatively resistant to treatment, and long-term survival for those patients, in our experience, is really related to our ability to get them to transplant. They need a transplant in order to have good long-term control of the Richter's transformation aspect of their disease. Second cancers, or second primary cancers, are things like skin cancers, melanoma, non-melanoma, solid tumors, lung cancer, etc. And there's some controversy in the true incidence of those. It's difficult to track them. Generally, the data indicates that there are a higher incidence in patients with CLL. We think it's potentially related to the immune defects that arise because of the CLL. It may also be related to the treatment that they receive by virtue of that treatment, or by virtue of the fact that the treatment is immunosuppressive and further suppresses the immune function. But those second cancers also increase at higher frequency in patients with CLL. So it's very important to screen for those things that we can screen for. Going to the dermatologist once a year, getting your skin evaluated for non-melanoma and melanoma lesions. For men, the standard screening for prostate, for colon cancer, I think is important to stick to, adhere to, and for women, breast and colon are the cancers that we screen for.
Can I just absolutely highlight that no one gets skin cancers more than the current Australian patient with CLL. All right? Every patient, whether they're 40 or 80 with CLL in Australia, has grown up in an environment where there was no, sunscreen. I remember, peeling noses and bleeding noses as a child because we never applied sunscreen. It's that whole complete lack of awareness. So there's already that much, much higher incidence of both melanoma and non-melanomatous skin cancers. And I think nothing highlighted it more to me was when I walked past an ABC TV interview a couple of weeks ago and saw Clive James being interviewed. And he's a very famous Australian poet and commentator and author who lives in London and has been living in the UK for decades. And he was being interviewed, and I walked past him on the TV, and there he is with a big patch on his forehead from the removal of yet another skin cancer, and he was saying he had leukemia, and instantly he said, it was clear to me that he had chronic lymphocytic leukemia. He was talking about the life he's had 2 years after he was supposed to have died, having access to a new therapy, and that's a completely different point. But he's clearly got the signs of recurrent skin cancers, and I think it's really, really important for patients with CLL to be absolutely meticulous and be on very close terms with their dermatologist.
I just wanted to back up to the complications that we might see in terms of initiating therapy, because there was a couple things I think that we should mention that weren't mentioned. One is that when patients are untreated and they start a treatment and they have a fair amount of disease, we can see rapid death in the cells, and it can cause a complication called tumor lysis syndrome. So typically we'll put patients on a drug called allopurinol, which helps the kidneys clear out the toxins that are released from the leukemia cells when they die. So tumor lysis syndrome is something you should be familiar with if they're talking to you about initiating therapy. The other thing is an increased risk with chemotherapy, at least, of infections or reactivation of viruses. So we use prophylaxis for herpes virus with acyclovir or valacyclovir, typically for patients going on chemoimmunotherapy treatment. And for previously treated patients who are receiving fludarabine or steroids, we will give them PCP prophylaxis or pneumocystis prophylaxis through their treatment for both of the drugs, and then for a period there isn't a standard, but for some period after the completion of the treatment while the immune system is recovering from the chemotherapy.
And aren't the monoclonal antibodies liable to reactivate hepatitis B? Isn't that another big issue?
Correct. So your physician should check if you're going to get a CD20 monoclonal antibody, if you've been exposed to hepatitis, and if you have, then there are some additional testing, and sometimes we put patients on prophylaxis for reactivation of Hep B if they have been exposed and have some indication of activity.
Well, now we're going to get into the fun part. Now this is a decision that as patients will often face. If we're not part of that lucky group that goes on and never needs therapy or does extremely well with FCR and we relapse, what are your second-line therapies? And let me start with you, Dr. Trotman, in terms of you have a patient that comes back. What would your approach be? Is that where you try to push to get the FISH test done? And what you're going to approach to be to a patient who's now failed your frontline therapy?
I don't like using the term failed frontline therapy because that frontline therapy may have kept the patient in remission for 6 or 7 years or whatever, and certainly if it has, I would reconsider revisiting that frontline therapy, although maybe with a little bit of caution in the modern era when you know You know, you've got to be thinking, you know, when I'm thinking of what I'm going to be treating a patient second line, I'm thinking about the implications of that on what I'm going to be treating them not just now, but also probably in third line or fourth line, you know, if they're fit enough and well enough to be able to tolerate future therapies. Because unfortunately, you know, once you're approaching second line treatment, you've got to think about the consequences of that treatment for the future. We do have, so unfortunately we're in the tricky situation that if someone who was frail, who had, say, you know, received chlorambucil alone in the past, that I can't actually offer them chlorambucil again with obinutuzumab because it's only allowed in the frontline setting in Australia, but I could offer them bendamustine with rituximab, which I think could be a very reasonable, as you know, is a much better tolerated treatment than fludarabine and cyclophosphamide and rituximab in the older patient population. So that would certainly be something I would be considering. In the younger patients, it obviously depends on, you know, how long their remission has been, whether I would consider re-exposing them to fludarabine, cyclophosphamide and rituximab again. But you know, if their remission has been very short, you know, for most patients, I'm really scrambling to look down the list and see what clinical trials are potentially there for them that I could send them to, not just at my hospital, but anywhere else around within a, you know, reasonable geographic access for them. Because certainly, you know, I've had patients, you know, come down from Newcastle, from Dorrigo, from, you know, all around Sydney to participate in our trials, and likewise have sent them to other parts of Sydney. So I'm not sure I've answered your question well enough.
Yeah, it's a difficult topic, and it's a difficult issue, and if you ask 5 different physicians what the right answer is, you're going to get 10 different answers, because there are a lot of options. In the US, we have a lot of drugs now that are available that weren't previously available. That's opened up things for us. At Anderson, we try to put everybody on a clinical trial, and we don't have any shortage of clinical trials to offer patients right now who have relapsed disease. So there's a lot happening in relapsed disease. There's a lot of options, and I would agree that clinical trial, I mean, the only way we're going to make continued progress with this disease is if we're able to treat patients on clinical trial and to learn what works and what doesn't work. And so I think if there is any situation to think about and to pursue going on clinical trial, it's in the relapsed setting if your options are limited for standard of care, which it sounds like.
Sorry, I have fallen into the great trap that we as treating clinicians often do, is forgetting about what's just become available last week or last month. And I should point out to everyone here that there are 2 agents that are now available on a named patient program. And that's probably a good segue, perhaps, if I can introduce the 2 agents and leave it to my international colleagues to explain them. We have both ibrutinib available for patients who have relapsed disease, as well as idelalisib on compassionate programs.
Dr. Wiesner, do you want to talk about those 2 and how they might fit into your relapsed patients?
So the big thing about these 2 new drugs is that they're totally different from chemotherapy. So once maybe chemotherapy has done its job and it's not working anymore, and you need a second treatment, the good thing about these agents is that they come from a different angle in how they attack the CLL cells. In some ways, these are smart drugs. They flip a switch within the cells, pretty specific to the CLL cells, and can stop them primarily from growing, also reduce a lot of the disease that's there, usually creating space for normal blood counts to recover. But they, most of the time, don't get patients into what's called a complete response. So like with the first line FCR treatment, where most patients go into a complete response, that's not the case with these drugs. But they're pills. They can and have to be, as far as we know at this point, they have to be taken for very long periods of time, years. But they're usually well tolerated. So it's a completely different, whatever we want to call that, it's a completely different treatment, a completely different angle of approaching the CLL. And so I think it's just desirable from the point of view that if one approach hasn't worked anymore, to be able to switch to a completely different one. So I think that's a very good progress really for patients here, that there's access to these drugs.
I'm trying to think of what I can add to that. I think, so there are two options. The choice between those two options for us as standard treatment is sort of driven by tolerability and the toxicity profile and the patient characteristics in terms of, do we select ibrutinib to treat the patient, or do we select idelalisib? They have a different toxicity profile. They work differently than chemotherapy, but each one of them has different characteristics and features about it that we use to direct treatment. Ibrutinib is very, very active, I would say, in terms of the activity, in terms of the duration of the response that patients get and the quality of the response. My experience has been that ibrutinib is probably superior, but there are some things about ibrutinib that may prevent us using it for individual patients. Patients on an anticoagulant called warfarin, and patients who develop some intolerance or side effect or toxicity associated with it.
I have to ask about, though it's still not approved, a drug that was developed in Australia, which is ABT-199 or venetoclax. Dr. Trotman, do you want to talk about that a little bit?
Look, it's a very exciting agent. Ibrutinib and idelalisib sort of put the lid on the CLL, and I like your flip the switch analogy. I'm going to use that, in terms of switching off the activity of the cells. But they keep the leukemia in a holding pattern. Whereas venetoclax, the ABT-199, attacks and stops this BCL2 molecule, and really is very effective at gaining remissions even on its own without antibody, and maybe just as good on its own as it is with rituximab. No one's actually done the comparative trial. And for a number of patients who've been receiving venetoclax in the context of clinical trials, they've had some very rapid, very impressive results to this oral tablet, which is extremely well tolerated, with one particular side effect that I'll come to. I think there are two big issues with venetoclax that we're seeing in clinical trials, is because it's so effective. We've seen this tumor lysis syndrome that my colleagues have mentioned, and so for patients who have very bulky disease, very high white cell counts, we actually have to admit them to hospital, and we have to monitor them very, very carefully as we gradually increase the dose of the venetoclax. And there's what we call a ramp-up period over 5 weeks in the context of clinical trials, where we increase the dose of this venetoclax because it is so effective at effectively killing off the tumour cells. I think it will be quite a while before venetoclax becomes freely available for patients. And I think what is more exciting than just venetoclax alone is trying to see whether venetoclax can be combined with other agents to get deep remissions that then we can actually stop the treatment. And that's the huge appeal of venetoclax. With ibrutinib, with idelalisib, we have to continue on these treatments indefinitely. A goal of therapy for many patients, not all patients, would be to get into remission and be able to stop therapy. But we're very, very early on in the venetoclax development program, but it's certainly a very, very exciting agent. The other big side effect of venetoclax, aside from its initial tumor lysis, is the neutropenia. and neutrophils are those cells that are so important to help protect us from bacterial infections. And I've seen neutrophil counts plummet on venetoclax, but fortunately it's very sensitive to that GCSF injection that stimulates the neutrophil production. So I think we'll have to iron out that issue.
Want to add anything, Dr. Wiesner, or to that, or?
I think this is an absolutely fantastic drug from what it attacks in the CLL cells, from the activity it has shown in the early clinical development, and also just from the fact that this is again a drug that comes even from a different angle than the other two, ibrutinib and diadelisib. So that really with time there should be a selection of treatments that come from very different angles, and if there is resistance to one of the drugs, I think we're starting to see that switching from one of these new agents to the other is possible and brings responses again. So I think looking forward, I'm very hopeful that having all these tools in place will really change how CLL is treated and how well people do.
So it might not be such a bad thing to go from one to another agent. We might not have to use them in combination, although ideally perhaps that would be, on the face of it, the ideal thing to get deeper, more prolonged remissions.
So a last question for all of you, and then we'll take a quick pause and then open it up to Q&A. But you've talked a lot about clinical trials. Tell us where you see clinical trials and what kind of research you're itching to do that you're really excited about that you're doing or thinking that really needs to be the next step. So do you want to start with that, Dr. Weir?
Sure. So in terms of the interesting approaches and things that are fascinating to me, one is the prospect of eliminating chemotherapy and all of the problems that we see with chemotherapy. I think we may even be there right now with venetoclax, because my impression of our experience has been that the activity rivals FCR in terms of the response rate and the quality of responses, even with venetoclax by itself. So the prospect of getting rid of chemotherapy is, I think, I'm highly excited about that. And as you know, my background is in immunology, and I think the prospect for cure for patients with CLL is going to come with some immune-based therapy, whether that's cellular therapy in these CAR T cells.
Can you just stop there for a minute and explain a little bit about CAR T, because that's a pretty hot topic.
So CAR T cells are T cells, a patient's own T cells, which is another type of lymphocyte that circulates around and has a different function than B cells. That have been modified in the laboratory to express a receptor that targets and will seek out and find the leukemia cells. There's a marker on the leukemia cells called CD19, and there are these genes that have been developed and inserted into T cells that target the T cells to kill the B cells, malignant B cells. CD19 is also on normal B cells, so one of the problems with this strategy right now is that you don't just get rid of the leukemia cells, you're also getting rid of normal B cells, and so that is in and of itself immunosuppressive. We have been working on a CAR against ROR1, which is a protein that's expressed in CLL cells, but not on normal B cells. At least in our experience, not on normal B cells. And so we think that that may be one strategy to get around the immunosuppression you see by targeting CD19. So it's a way to retrain the immune system to eliminate the leukemia cells. And there's been more work has been done so far in acute lymphoblastic leukemia, and there's certainly is quite a bit of data now that shows that it's an effective strategy to treat the disease. And I think it's one area that we need to focus on in order to make advances. So there's the T-cell strategy with CAR Ts. The other strategy that we've been working on recently at Anderson is use of some immune modulating monoclonal antibodies against PD-1, which is a suppressor molecule in T cells that when they express it and it's stimulated on the T cell, it will put the T cell to sleep, so to speak. So we're working on antibodies that block that interaction, and that may reawaken the T cells to eliminate leukemia cells. PD-1, PD-L1, and then there are some others that we're working
And these are
on.
being used in solid tumors now, like melanoma
Yes.
and lung cancer, and that
Yes.
they're coming over to hematology now.
So the immune-based strategies, yeah, that's true. The immune-based strategies and the prospect of getting rid of chemotherapy are highlights for me.
Dr. Trotman?
I'm Australian, I've got to say venetoclax.
No, venetoclax is amazing, and it was Peter Max. Where is that? Was that where?
Peter McEnroe, Melbourne, and WEHI, the Walter Eliza Hall Institute, and all credit to sort of then Abbott, now AbbVie. They've been working on this for more than 20 years, and I think I'm not one normally to give industry a big pump, but all credit to them for sticking with it. Despite all the problems they had with their precursor to venetoclax, called navitoclax, which caused very low platelet counts. So I think that's the one on my watch list.
Dr. Wiesner?
I just agree with both of my colleagues. I think that the combination potentially of novel agents, so recreating what was done with chemotherapy, of combining different agents, now with the new agents, maybe in 5 to 10 years, that really becomes a home run, becomes a curative treatment without ever needing chemotherapy. But I'm also very impressed really by the immune-based approaches. And for about 20 years we've been saying the way to cure CLL is going through transplant. The transplant from a sibling or from a donor, that's the way CLL is really curable, and it shows the power of having this immune system eliminate the CLL cells. And there are problems obviously with transplant, but hopefully CAR T cells or maybe even these new antibodies that we refer to as checkpoint inhibitors can mobilize the immune system to get rid of the CLL cells. So I think that is, both of these approaches are really exciting, and there are so many of these approaches that really having patients interested in coming for clinical trials will be important to actually move these things forward. There are so many things to test that are really well founded in the science and that have good prospects of making a huge step forward, but it will take the clinical trials to work it out.
I love the fact that I can't give a prognosis to the newly diagnosed CLL patient who walks into my office today. I can't pull out my crystal ball and predict how many years and years they can expect to survive for. Because, just a couple of years ago we were desperate to get bendamustine, which is a great chemotherapy, very effective chemotherapy for chronic lymphocytic leukemia. But now we've said, we've got bendamustine, but we want all these other drugs.
What you can say is that you're confident that it's better than what they'll read on the
Absolutely.
internet or...
Absolutely.
Right. And all when you look at statistics, you're always looking backwards in time. So when you see those terrible curves, that was going maybe up to now, but going backwards in time. I mean, there's, one of my things is there's never a good time to have CLL, that there's never been a better time to have CLL. I do want to take one tiny step backwards, and maybe I'll ask you the role of transplant, because you mentioned that's changed quite a bit. Can you just, I promise this will be the last question, the role of transplant in CLL, where do you see that fitting in? And I know it's shifted.
Diminishing. I'll leave it to my colleagues. I think it's very much diminishing. Look, my patient population is probably very different from my, the patient population at MD Anderson and NIH, and the vast majority of my patient population are not patients who are eligible for allogeneic transplantation. And I think for them it would be the fastest way to kill them.
I'm having a hard time recalling the last patient that I sent with CLL for transplant right now. It's been a while. It's been a couple of years at least, so it's diminishingly small.
I did send one 2 years ago with fructis.
I totally agree that it's diminishing, but I think what the experience with transplant tells us, and there is quite an experience with transplanting CLL patients, is that the immune system you transplant can cure the disease. I think that's the important take-home message, and I think that also lends us some more confidence that if we get these immune modulatory drugs right, that maybe we can achieve the same without the transplant. That said, we currently have still a few patients who are not fully, are only temporarily well served by the new agents. Some of the younger ones, yes, it's a small group, but some of the younger ones that have problematic CLL that start developing breakthroughs on ibrutinib or idelalisib, for some of these patients, maybe transplant is still a great option. It's diminishing, but there may still be a few patients where it might be the right choice.
May I ask a question of Dr. Weir? The CAR T-cell technology is obviously very exciting. Do you envisage it eventually being, so well developed a technology that it's going to be affordable?
Yeah, I do. So there's a lot of work. Right now it's somewhat cumbersome, and the underlying comment that I would make is that success is, what's the expression? I'm having a hard time remembering. Success is the mother of invention, or necessity is the mother of invention. And so if we sort things out and we show that this is very effective, things will evolve. And in the past, it used to take at least a month to produce a product. That's been shortened down now to 2 weeks. They are individualized products, but it's becoming less and less costly. And the pharmaceutical companies who are involved in developing this treatment have heavily invested in developing production sites and putting in an infrastructure where we can at least do the clinical trials. And then I think as we show, hopefully as we show this to be an effective treatment, the capacity and the cost will be manageable so that we can offer it generally to patients. Right now it's something that is sort of like transplant. It'll need to be done at a specialized institution by people who are savvy in managing this and the complications that we see with it. But I think, as I said, I think it will evolve. If it ends up being effective and works, then everything will fall into place eventually.
So I'll just ask you to just make a final comment or any advice you'd want to give to a patient or a caregiver with CLL now, and then we'll take a quick break for some tea. And I think Dr. Weirda has to take off, but I think Dr. Trotman and Dr. Wiesner will stay to answer some questions after we have a quick break. So
my advice is share your concerns with your treating physician. All right? Don't keep them bottled up.
I think that we've covered a lot of topics, and one of the things that has resonated with me through the years is something that a friend of mine by the name of Paulo Guia said to me a while ago, and that is that with CLL you're almost never late. So for me that means that this diagnosis and this disease, you have some time to review your options, to get information, to read, to think about your decisions, and to make an informed decision about how you want to work with your physician to manage your disease, or if you want to find another physician, or however you want to participate in the care of your disease. The disease is typically not rapidly growing, and there's some time. Now there are some exceptions where things happen, and for example, Richter's transformation, you don't have that same luxury, but for the most part, there's the luxury of time with this disease, and you can be patient and very deliberate about what you do.
Yeah, I always say that when you get CLL, there's a lot of things you get, but one of the things you always get is time, and you always have time to plan out your strategy. Give you the last word.
So let me take up the time. I think time is working for you. Time is working for patients with CLL in that there is a return coming for all the years of investment, both in research labs, in industry, by public funding of this research, that there's really a dividend coming out of progress with new agents, new approaches. And so time, I think, is working for you.
I can't leave you with the last word because I would like to thank the two of you for leading us over the years in all that research to help advance things for us all.
And thank to our whole panel here for, I think, what's been a very informative discussion about CLL. So thanks so much for giving so much of your time and for the research. We're hearing from the docs who are actually doing this research. We're not just talking about it and reading it, but actually doing it. So thanks so much for all of you and your time. Thanks very much.